So hello friends, and you are welcome to our series where we are going to talk about maxillofacial trauma and the management of maxillofacial trauma. So Bonker provide us varied and various type of plates, like they provide us straight plates with gap, without gap, 4-hole plates, 4-hole with gap in 1.5, 2 and 2.5 mm respectively. These are the few of them. As you see here, they are providing us plates for orbital reconstruction. They are providing us plates for nasomaxillary floor reconstruction. They are providing us plates for zygomatic arches reconstruction. They are providing us plates for maxillary fractures reconstruction and the mandibular fractures reconstruction. Variety of screws. They have 1.5, 2 and 2.5 mm work. Now coming to the part of trauma. Today in this video we are going to cover are mid-face fractures involving the maxilla and surrounding facial bone. They are classified into Lefort 1, 2 and Lefort 3 based on the fracture patterns. So let's discuss the Lefort 1 fracture on this skull. As we know, this is a floating maxilla fracture. So the horizontal line which starts from the nasal septum from here and it travels to the lateral maxillary walls like this above the apices of the teeth. These are the apical region of the teeth. So line travels above this on the lateral wall of the maxilla and maxillary sinus, and then below the buttress, this is the zygomatic-maxillary buttress. Below the buttress, it line extends till the lower part of the pterygoid plates like this. This is a Lefort 1 fracture line. This is also known as classical Lefort 1. Clinical features includes mobility of upper alveolus or palate, malocclusion, epitaxis, maxillary edema, ecchymosis of the buccal sulcus. Coming to a treatment protocol, first and the foremost is the airway stabilization, then intermaxillary fixation if needed, and open reduction and the internal fixation, and plate at the zygomatico-maxillary buttress and pyriform rim. So we are going to stabilize the patient airway if needed, and then we are going to go for a intermaxillary fixation like IMF with the help of arch bars. Once the intermaxillary fixation is achieved, then we proceed for the open reduction and the internal fixation, that is known as the plating. Reconstruct the Lefort 1 fracture. We are going to use mini plates, and mini plates, the choice is 2 mm plates or 1.5 mm plate. 1.5 mm is the thin plate and a thin screw which basically help us to get maximum control over the thin plate of maxillary sinus. Otherwise, I will recommend go for a 2 mm plate at this region, at this pillar, pyriform pillar, and a 2 mm plate at this region, at zygomatico-maxillary buttress. So, as you see, this is a edentulous maxilla, और edentulous maxilla में भी Lefort 1 सेम इसी कंडीशन में प्रोसीड करता है, बट यहाँ पे ये हमारे पाइसिस तो नहीं है टीथ के, जो कि दांत निकल गए हैं विद टाइम पेशेंट के. तो वी विल से लाइक दिस कि जो लाइन है हमारा वो नेजल सेप्टम से स्टार्ट होता है, लेटरल मैक्सिलरी वॉल के अराउंड ट्रेवल करता है मैक्सिलरी साइनस के ऊपर, एंड देन अगेन लैंड अप एट द pterygoid plate and it fractures the pterygoid plate at lower third level. Treatment protocol or treatment modalities in open reduction internal fixation in case of edentulous maxilla. यहाँ पे आपको intermaxillary fixation achieve नहीं होता है. So if it is a unilateral fracture, so the good part is कि maxilla अपने point पे ही है. If it is a unilateral fracture or if it is split bilateral fracture too, then maxilla अपने part पे ही है, ये move नहीं किया है यहाँ से. So it's good for us that we can directly plate this system, but plates are placed according to the pyriform aperture and zygomatico-buttress area, as these are the strong maxillary pillars from which the force is going to pass in future or in present. The entire maxilla is floating. It's like a bilateral report one is there and a patient is edentulous. Then अगर हमें open reduction internal fixation करना है, in this case we are going to use raw maxillary disimpaction forceps. Basically this forceps help us to stabilize the maxilla at a point where we want to stabilize it and disimpact the maxilla if it floats and disimpacted and impacted at a higher level in the cranial region. So that's all, and now we are moving to the plating and we will show you the plates, how we place the plates. So coming to the plating, as we are considering that this is our fracture line and this is the pyriform aperture, and we are going to plate this fracture at this point and at zygomatico-maxillary buttress at this point. So here we are going to use a 2 mm drill bit. This 2 mm drill bit is going to give us access to the holes so that we can stabilize our plate with screws at this region. See the difference between two. This is a burr and this is a drill bit. Stabilize this plate anatomically at this point like in a fashion that it is closely adapt to the bone, following the bone anatomy at this point. We are able to bend our plates according to the anatomy, and from other hand I will use this plier and I will bend it in the desired fashion where I want to bend. We go 90 degree to the hole, and once the hole is done, we can go for a bicortical or a single cortical engagement as per the need. We will pick the screw from the plate. It's quite easy for us to directly screw this hole with this screw in a single go. Once the plate is holed, we leave this screw here in this point and we will drill the next hole. Coming to the next hole, like the previous one, we will hold the nut with this sleeve. When the screw is grabbed, we will place this in the desired hole. Anatomical consideration in this area is infraorbital nerve, which just come out of the infraorbital foramen here. So this is the anatomical consideration. Second anatomical consideration is the lateral wall of the nasal cavity, and once the all screws are in the place, we will remove this sleeve. This will help us to get the direct screwdriver, and with this we can tighten the screws up to the desired level. This is the fine torquing which bring with this first point. So we must have a good flap here so that plate must not be exposed afterwards and they must be rigid. So like this fashion, one plate is here and other plate is the zygomatico-maxillary buttress region. ensure us a rigid fixation, open reduction and internal fixation approach. Points to be considered while treating a Clifford 1 fracture is you must follow the anatomy, you must honor the anatomy, like you must have to take care of your infraorbital nerves and vessels. You must have good take care of apical part of your teeth, roots of the teeth. They must not get damaged. The lateral nasal wall must not be damaged, and anatomically the fracture fragments must be reduced to the closest proximity to get the best results. The things which I want to say is flap must be so loose that they can cover the entire plate without any stretching. It must not stretch out so that the flap your plates must not be get visible. So why we go with the bonker is the flexibility of the system. Plates are that much flexible which they need to be. They can easily adapt by the instruments according to the anatomy. Screws have very precision. Their heads are so precise that they can get into the plate hole completely. All these make us to use this system over any other system. And the last is that this is a system with a very price effective range. These all titanium screws and plates come at a very affordable price. So thank you, and I want to say is before reduction of any fracture, kindly take care of the anatomical considerations. Once if you are using the correct anatomical screws and plates according to the anatomy, they will give you the best results. Every plate is not designed for every anatomy, but we have plates for every anatomy.